The nighttime pill that doubles your fall risk and steals your memory, the anticholinergic trap. You're not just getting older. That fog, those stumbles, that fear of falling often comes from a harmless nighttime pill quietly stealing your independence. Boxes that say PM nighttime or helps you sleep hide ingredients that can nearly double your fall risk and dull memory after 60. Today you'll learn exactly which ingredients to avoid, safer swaps for sleep and allergies, and the right way to talk to your doctor. I'll show you the label trick that saves you tonight, the 2-week reset that clears the fog, and the one mistake that ruins everything. More than 10,000 viewers have used this exact checklist to cut their PM pills without chaos, and clinicians in our community keep recommending it. Let's start by finding the chemicals hiding in plain sight tonight. The trap defined: anticholinergics in plain English. You've heard the term anticholinergic, but here's what it actually means in your body. Your brain and nerves use a messenger called acetylcholine. It's a signal for attention, memory, balance, and even bowel and bladder control. Anticholinergic drugs block that signal. A little block might make you drowsy. Stack small blocks day after day and you get slower reflexes, fuzzy thinking, constipation, dry mouth, blurred vision, and dangerous nighttime wobble. The part most people miss is cumulative load. You might not feel much from one pill, but anticholinergic burden adds up across products and doses. 1 PM pill here, a nighttime sleep aid there, plus an old prescription, all those small points add up to a high burden that predicts worse outcomes. Clinicians even use scoring systems like the Anticholinergic Cognitive Burden Scale to total it. Higher scores track with more confusion, delirium, and falls, especially in older adults. So what are the usual culprits? In the over-the-counter aisle, 2 names lead the pack for sleep: diphenhydramine and doxylamine. They're first-generation antihistamines that cross into the brain and shut down acetylcholine. They're the PM in many pain relievers, the nighttime in many cold medicines, and the sleep in classic blue and green boxes. If you see diphenhydramine or doxylamine on the active ingredients, that's the trap. On the prescription side, a few regulars carry strong anticholinergic effects: oxybutynin and some other bladder meds meant to calm urgency, tricyclic antidepressants like amitriptyline used for pain or sleep, and certain older antipsychotics and anti-nausea drugs. Not every person will be on these, but when they're combined with a PM habit, the burden can climb quickly. Here's what high-quality data show. In older adults with mild cognitive impairment or dementia, adding 1 level 2 anticholinergic on the ACB scale increased the day-to-day hazard of a fall or fall-related injury by 56%, HR 1.56, 95% CI1, 16.2, 10. Combining a level 2 with a level 3 drug nearly doubled the risk, HR 1.96, 95% CI1, 43.2, 69. Even multiple level 1s together nudged risk up, HR 1.16, 95% CI1, 031, 32. The danger is the combination, not just one label. Now here's the hidden combo effect nobody warns you about. Picture allergy season. You take an old-school allergy pill that makes you drowsy. That evening your back acts up, so you grab a PM pain reliever. Still not sleepy, you add a separate nighttime sleep aid. 3 products one night, and all 3 can contain the same anticholinergic sedative. That's a triple hit to your memory and balance circuitry. The labels don't shout this. You only see it if you check the active ingredients line by line. What does this feel like in real life? It starts as just groggy. Mornings feel heavier. You move a little slower getting out of bed. Your mouth is dry, your vision is a touch blurry, and you find yourself squinting at small print. Reaction times stretch out a beat. That beat matters when you shuffle to the bathroom at 2 a.m. If you also happen to be dehydrated, have lower body weight, or have even mild memory changes, that beat becomes a fall. A quick emotional win from a viewer captures this. Sarah, 68, had used diphenhydramine most nights for years and thought fog was just aging. She tapered over 3 weeks while adding morning light and a steady wake time. On day 10, she woke clear and cried, not from sadness but relief. I forgot what clarity felt like. And it's not just falls. There's the bowel and bladder piece. Constipation from gut slowdown, urinary retention from bladder muscle relaxation, and ironically more nighttime bathroom trips because you're chasing hydration or your bladder is misfiring. In the brain, the fog can escalate from forgetfulness to confusion. In some people, especially in the hospital or after illness, it can tip into delirium. Before you think, I'll just stop cold turkey, there's a catch. Long-term nightly use can create rebound, worse sleep for a short stretch, snappier allergies, or edgier bladder symptoms as your system rebalances. That's why we don't rip the bandage off. We lower the burden with smart swaps, spacing, and support so you stay comfortable while your brain clears. Who's most vulnerable? Anyone over 60, people who don't drink much fluid, those with low body weight, anyone with balance issues, and those with existing memory concerns. Add alcohol, dehydration, or low sodium, and the risk spikes. It's a perfect storm when you layer a sedating pill with a dark path to the bathroom and multifocal glasses that distort depth at night. Here's the shortcut nobody teaches. Ignore the front of the box. PM, nighttime, for sleep, and dreamy moon graphics mean nothing without the active ingredient. Flip the box, find active ingredients. If you read diphenhydramine or doxylamine, that's a no after 60. And check every bottle, even within the same brand. Brand families shapeshift formulas. The daytime bottle might be non-drowsy, but the multi-symptom version sitting next to it could hide the sedative. One more nuance. Non-drowsy allergy often means second-generation antihistamines like cetirizine, loratadine, or fexofenadine, which have far lower anticholinergic activity and don't usually cross into the brain the same way. Different category, different risk. Also, if a cold medicine says severe or multi-symptom, assume a mix. Many bundle a cough suppressant, a decongestant, and yes, an anticholinergic sedative. That's how people unknowingly double or triple dose. If you remember nothing else from this section, lock this in. Acetylcholine is your attention, memory, and balance signal. Anticholinergics block it. The more total block you carry across products and days, the groggier your brain and the slower your reflexes. That's the setup for falls, confusion, and a steady drain on independence. Now that you can spot the chemicals by name, let's move from theory to action. We're going to raid your cabinet the right way, use the label trick to save you tonight, and build a quick keep, toss, and swap plan you can finish in 10 minutes. Cabinet audit, the label trick that saves you tonight. Grab a trash bag, a pen, and 3 containers or grocery bags. Label them keep, swap, and discuss. We're doing a 10-minute sweep that can literally prevent a 2 a.m. fall tonight. First, the rule that saves you: ignore the front of every box and bottle. Flip to drug facts. Go straight to active ingredient. You're hunting for 2 names, diphenhydramine and doxylamine. If either is listed, into the swap bag if it's over the counter, or discuss if it's a prescription combo your clinician needs to review. Start with the bedroom and bathroom. Nightstand, top drawer, medicine cabinet. Anything that says PM, nighttime, or sleep aid, flip it. Many PM pain relievers are just plain acetaminophen plus diphenhydramine. You do not need the diphenhydramine for pain. If it says acetaminophen 500 mg and diphenhydramine 25 mg, that's a swap. Now the allergy shelf. Pull every allergy product, even the dusty ones. Old bottles hide dangers. Discard anything expired, then check the rest. If you see chlorpheniramine, brompheniramine, or promethazine, those are first-generation antihistamines too. Move to swap or discuss. If the label says cetirizine, loratadine, or fexofenadine as the active ingredient, those usually belong in keep, assuming they work for you and don't clash with other conditions. Still, write the name and dose on your list. Next, cold and flu products. Severe, multi-symptom, and nighttime almost always bundle the sedating antihistamine. Look for doxylamine or diphenhydramine in those multi-ingredient mixes. If present, swap. If the product is purely dextromethorphan for cough or guaifenesin for mucus with no sedating antihistamine, that might be keep. If it includes a decongestant like pseudoephedrine or phenylephrine, pause. Those can raise blood pressure or disrupt sleep. Put those in discuss if you have hypertension, arrhythmias, glaucoma, or prostate issues. Check pain shelves for duplicates. Often, people own plain acetaminophen and a PM version. Keep the plain acetaminophen, swap the PM. If you use ibuprofen or naproxen, stick with daytime dosing and avoid any versions with sleep or PM. For joints, flag any topical gels or patches. Those can be safer for nighttime pain without sedating your brain. Those likely go in keep. Now visit the kitchen drawer or travel bag where stray meds hide. Older travel-size sleep aids are often pure diphenhydramine. Into swap. Also scan herbal blends. If the blend lists antihistamine or nighttime without clear actives, find the tiny font or look it up. Many natural night formulas sneak in doxylamine-like compounds via blends. If you can't verify, place in discuss. Here's the quick audit checklist. Front claims ignored. Active ingredient verified on every item. Hunt words: PM, nighttime, sleep aid, multi-symptom. Red flag actives: diphenhydramine, doxylamine, also first-gen antihistamines. Note decongestants: pseudoephedrine, phenylephrine. Discuss if heart BP issues. Separate plain single-ingredient meds from combos. Toss anything expired or unlabeled. As you sort, create your log for your doctor and pharmacist. Use a scrap paper or your phone. Name of product and brand. Active ingredient S and total dose per pill teaspoon. How often you take it, be honest, nightly, as needed, that became daily. Why you take it, sleep, allergies, pain, bladder. Time of day you usually take it. This log turns a vague conversation into a focused med review. If you take a PM pill for sleep, write that clearly. If you doubled up during a cold, list the 2 products you combined. That's often where we find unintentional stacking. Brand shape shifting is the booby trap. The same company may sell pain relief PM, allergy, sinus, and nighttime severe. 4 boxes, 4 different ingredient mixes. Never trust color or brand family. Read every drug facts panel like it's a food label for a serious allergy, because for your balance and memory it is. A quick win tonight. Set aside your PM products and place your plain pain reliever acetaminophen where you'll reach first. If you typically use a sleep aid, do not go cold turkey if you've used it nightly for weeks. Instead, move it to discuss and we'll show you a taper and swap in the reset phase. For allergies, bring forward a second-generation option like cetirizine or loratadine if you already own it, and move first-generation bottles to swap. Don't forget bladder and nerve pain prescriptions. If you find oxybutynin, tolterodine, amitriptyline, or similar on labels, add them to discuss. Do not stop prescriptions abruptly. The goal is to flag them for a swap conversation, not to scare you into sudden changes. Finish by photographing your keep and discuss groups. Send the discuss photo and your med log to your clinician's portal or bring printouts to your next visit. Put the swap bag out of reach tonight. You've just lowered your anticholinergic burden before bed. Quick give before ask. I've included a free printable cabinet audit sheet and the 2-minute drug facts checklist. No email needed. Share it with a friend who has a PM bottle on the nightstand. Couples who audit together cut hidden anticholinergics twice as fast. You did it. Labels beat marketing and you now read them fluently. Next, I'll show you why these small changes matter most after 60 and how they tie directly to balance and memory. Why falls and memory suffer, the mechanism that matters. Let's connect the dots between the label you just flipped and the way your body stays upright and sharp. Acetylcholine is not a sleepy time chemical, it's your attention dial, your find your footing signal, and the start button for muscle activation. When you block it, you dim 3 systems at once: brain focus, inner ear vestibular calibration, and the postural reflex arcs that fire tiny stabilizing muscles around your ankles, knees, and hips. That's why the same pill that makes you drowsy also makes you wobbly. The thing most people miss is how much your balance depends on lightning-fast corrections. Your vestibular system inside the inner ear tracks head position, velocity, and acceleration. Normally, a small sway triggers a microcorrection in a fraction of a second. Calf fires, toes grip, hips countershift. Anticholinergics slow that loop. The result is more sway, slower foot placement, and a longer pause before muscles kick in. On carpet, you might not notice. In the dark, half asleep with a full bladder, that delay is a misstep. Now layer in nighttime dosing. Most PM pills peak when you're sleeping, so the carryover sedation lands right when you sit up for the bathroom. Blood pools in your legs, blood pressure dips, and your brain gets less oxygen for a few seconds. Normally, your autonomic nervous system tightens vessels and steadies pressure. With anticholinergic drag, that response is blunted. Stand too fast and you feel the head rush, only your feet aren't ready to catch you. On the cognitive side, acetylcholine is critical for attention and memory encoding. Reduce it and your brain struggles to filter distractions, form new memories, and hold a plan in working memory. That's why the just groggy phase includes misplacing items, losing your train of thought mid-sentence, or blanking on a name you knew yesterday. Keep the burden high and the fog thickens into confusion, especially during illness or after surgery when the brain is already stressed. Here, where compounding risks sneak in. Alcohol is another depressant. Even a small nightcap amplifies sedation and slows reaction time. Dehydration concentrates the drug in your system and lowers blood pressure when you stand. Low sodium, common after vomiting, diarrhea, or some diuretics, worsens dizziness and confusion. Put those together with an anticholinergic and the same bedroom becomes an obstacle course. You might be thinking, but I only take 1 pill. Remember, burden is cumulative. Your allergy tablet at breakfast, your PM pain reliever before bed, and the separate sleep aid after lights out can all carry the same blocker. Even a low anticholinergic medication taken daily can tip the balance when combined. Clinically, higher cumulative scores are linked with more delirium, more falls, and more functional loss in older adults. That's why we care about total points, not single labels. And combinations matter. Adding a level 2 drug to a regimen that already includes a level 3 almost doubles fall risk, HR 1.96. Okay, so why does withdrawal feel rough? When you've used a nightly antihistamine for weeks, your brain and body adapt. Remove it abruptly and the histamine system rebounds, itchier nose, lighter sleep, a few restless nights. Your cholinergic circuits also upregulate to compensate. When the break disappears, you can feel wired or edgy for a short stretch. That discomfort tricks people into restarting the pill thinking, see, I need it. The truth is, the rebound is temporary if you lower the burden gradually and add supports. Common mistakes here. Switching from diphenhydramine to doxylamine thinking it's different, it's the same trap. Adding a decongestant late evening, now you've traded fog for palpitations and insomnia. Or pairing your PM pill with a dark hallway and multifocal lenses that distort depth perception at night. Multifocals are great outdoors, but at night they blur the floor. Keep a single vision pair by the bed for nighttime trips. Let me give you a fast win you can try tonight. Before bed, put a full glass of water and a small snack on the nightstand, then set a motion light along the path to the bathroom. If you do get up, sit at the edge of the bed, feet flat, and count slowly to 10 while flexing your ankles. That primes your calf pump, stabilizes blood pressure, and wakes up the postural muscles before you stand. It's a tiny habit that cuts the head rush and buys your reflexes time. One more nuance that separates beginners from pros. Morning fog isn't only from the drug, timing matters. If you took a PM medicine at midnight after tossing and turning, it will still be active at 7 a.m. Move any necessary meds earlier in the evening under guidance, or better yet, swap them out. As we lower the anticholinergic load and firm up sleep anchors, regular wake time, morning light, no late naps, your acetylcholine signaling rebounds. People notice it first as steadier mornings, easier focus, faster gait, fewer stumbles. This is the payoff. Protect acetylcholine and you protect two freedoms, your clarity and your mobility. Next, we'll replace the nighttime antihistamine with safer sleep strategies that actually improve your days while guarding your nights. Safer sleep, what to use instead of nighttime antihistamines. Let's rebuild sleep without sabotaging your balance. We'll anchor the basics, layer gentle supports, and keep anything sedating off your acetylcholine. Start with the non-drug anchors because they set your clock so supplements actually work. Why this matters? When your circadian rhythm is steady, you fall asleep faster, wake less, and need fewer aids. The thing most people miss is that your wake time sets your sleep time, not the other way around. So lock in a consistent wake up 7 days a week. Then get 10-20 minutes of outdoor light within an hour of waking, no sunglasses if safe, eyes open to daylight. That light tells your brain, build melatonin 14-16 hours from now. Cap caffeine by noon. Keep naps to 20-30 minutes before 2 p.m. and skip them entirely during a reset week. What to do at night? A wind down that teaches your brain the sequence. Dim light 60 minutes before bed, cool the room, shut screens, or use audio only. Use the 3-2-1 rule, last big meal 3 hours before bed, last alcohol at least 3 hours before bed, and last fluids heavy 2 hours before. Small sips are fine. If you're awake in bed more than 20 minutes, get up, go to a dim, boring space, and do a calm activity until sleepy. That's stimulus control, the heart of CBTI. Bed equals sleep and intimacy, not tossing and turning. If you remember nothing else, here's the shortcut. Same wake time, morning light, no late naps, and don't battle the pillow. That single loop fixes more insomnia than any pill. Now supplements. Magnesium can help if low intake or muscle tension keeps you wired. Look for magnesium glycinate. It's gentle on the gut and less likely to cause diarrhea than citrate. Typical bedtime trial range is around 100-200 mg elemental magnesium, 60-90 minutes before bed. Start low for a week, assess, then adjust. Avoid if you have significant kidney disease unless your clinician approves. Common mistakes: taking huge doses that loosen your bowels or grabbing oxide, poor absorption because it's cheap. Melatonin isn't a sedative, it's a timing cue. Used right, it can help you fall asleep earlier or resync after travel. Keep doses modest often. mg about 2-3 hours before your intended sleep time for phase shifting, or 5-1 mg 30-60 minutes before bed for a short-term trial. Higher doses linger into morning and add fog. If you felt hungover on melatonin before, it was probably the dose or timing. Use it short-term while you lock in anchors, then taper off. CBTI is the gold standard for chronic insomnia. The American College of Physicians recommends CBTI as first-line treatment, and most older adults see meaningful improvement without pills. 2 core tools you can start tonight. Stimulus control: out of bed when awake, back only when sleepy, and sleep restriction, temporarily limiting time in bed to match actual sleep, then expanding as efficiency improves. This sounds counterintuitive, but it consolidates fragmented sleep. A simple entry: track your sleep for a week, average the actual hours you sleep, and set time in bed to that amount plus 30 minutes, not below 6 hours. Hold that schedule for a week, same wake time daily, then add 15 minutes when you're sleeping at least 85% of the time you're in bed. If this feels tricky, ask your clinician for a CBTI referral or a reputable digital program. Herbal options with lower interaction risk can be a gentle bridge. Chamomile tea or extract and lemon balm are commonly used. They're mild and generally well tolerated. If you're on blood thinners or have ragweed allergy, discuss chamomile first. Keep herb trials simple, one change at a time for a week, then evaluate. Stacking multiple herbs clouds the picture and sometimes upsets the gut. Pain, breathing, or movement can be the real culprit. If snoring, witnessed apneas, or morning headaches show up, ask about a sleep study. Treating sleep apnea beats any supplement. If restless legs, creeping sensations, or nighttime calf jerks wake you, bring it up. Iron studies and targeted treatment help. For pain-driven insomnia, schedule plain acetaminophen earlier in the evening if appropriate, add heat or gentle mobility, and avoid PM combos. If nerve pain is suspected, talk with your clinician about options and daytime sedation risks. Now the 2-week reset pattern that works. Week 1, establish anchors, morning light, and caffeine cutoff. Move the bedroom wind down earlier and use magnesium glycinate if you tend to tense up at night. If you've been using diphenhydramine or doxylamine, shift to every other night while you start the anchors. Don't add a second sedative. Week 2, drop the remaining anticholinergic nights, keep anchors, and consider a low-dose melatonin trial for 5 to 7 nights if sleep onset is still late. If you're up at 2 a.m., don't chase it with pills. Use stimulus control, a dim environment, and a quiet routine. Most people feel a dip on days 3 to 5 and then a steady lift. Clearer mornings, fewer awakenings, and faster sleep onset. If severe side effects or confusion occur during tapering, contact your clinician. Some cases need a faster or adjusted taper plan. Let me give you a micro story. A viewer in her late 60s swapped her nightly doxylamine for anchors plus 150 mg magnesium glycinate and used 0.5 mg melatonin at 9 p.m. for 5 nights. The first 3 nights were choppy. By night 6, she fell asleep within 25 minutes, woke once, and felt sharper on her morning walk. The difference? She stopped battling the pillow and trained her clock. One last protector: build a calming pre-sleep cue. You enjoy warm shower, light stretch, or breath work. Keep it repeatable and boring. Your brain loves patterns. And every night you avoid an anticholinergic, you protect both your sleep and your stability for tomorrow. Allergy season without the fog, antihistamine swaps. If sleep was the first trap, allergy season is the second. The mistake most people make is thinking all antihistamines are the same. They aren't. The older first-generation ones, like diphenhydramine and chlorpheniramine, cross into the brain and add to your anticholinergic burden. The newer second-generation options are designed to stay mostly out of the brain, so you get relief without the fog. Here's the quick map. First-generation antihistamines: diphenhydramine, doxylamine, chlorpheniramine, brompheniramine, promethazine. These are the ones we're avoiding, especially after 60. Second-generation antihistamines: cetirizine, loratadine, fexofenadine. These are generally preferred because they're far less sedating and have minimal anticholinergic activity. How do you choose among the second-gen? Think in terms of timing and sensitivity. Cetirizine tends to work fast and is potent for nose and eyes. Some people feel a little drowsy on it, so try it earlier in the day the first time and see how you do. Loratadine is gentler and typically non-drowsy. It can be a good daytime baseline during peak pollen. Fexofenadine is reliably non-drowsy for most and pairs well with driving or detailed work. If mornings are your busy time, fexofenadine or loratadine may fit better. If your symptoms spike outdoors, cetirizine can cover quickly. There's a catch that separates beginners from pros. Pills don't fix congestion as well as nose sprays do. For stuffiness, the first-line therapy is a nasal steroid like fluticasone or budesonide used consistently, not just when you're miserable. The reason this works is simple: these sprays calm inflammation right where the problem lives. Use good technique to avoid nosebleeds. Head neutral, not tilted back. Aim the nozzle slightly outward toward the ear and take a gentle sniff, not a hard inhale. 1 to 2 sprays per nostril daily through the season usually beats taking a sedating antihistamine at night. Add saline rinses as your daily rinse and repeat. A squeeze bottle or neti pot with sterile or distilled water flushes pollen and reduces the need for extra meds. Do this before your steroid spray so the medicine reaches the tissue rather than the gunk. Keep windows closed on high pollen days, shower off after yard work, and run a high-efficiency filter in the bedroom. These little habits mean fewer pills and less risk. Now, decongestants. Non-drowsy on the front often means there's pseudoephedrine or phenylephrine inside. Pseudoephedrine can raise blood pressure and heart rate and can wreck your sleep. If you have hypertension, arrhythmias, glaucoma, or prostate trouble, you need a conversation before using it. Phenylephrine has questionable benefit for nasal congestion and can still jitter your system. The smarter route is nasal steroid plus saline. If you need a short decongestant burst for a flight or event, confirm safety first and keep it brief. Let me show you a clean allergy stack with low brain impact. Morning, loratadine or fexofenadine. Evening, nasal steroid with correct technique. As needed, saline rinse after exposure. If eyes are the worst symptom, talk about antihistamine eye drops that don't sedate you. Reserve cetirizine for tougher days, testing your response when you don't have to drive. What if you've been on a first-generation antihistamine daily for months? Don't yank it. Step down. Start your second-generation option daily in your nasal steroid. After 3 to 5 days of overlap, reduce the old antihistamine to every other night for a week, then stop. Expect a few days of itch or sneezes as your system rebalances. That's rebound, not proof you need the sedating drug. Keep saline handy, keep your windows shut, and ride out that short transition. Common mistakes to avoid. Swapping diphenhydramine for doxylamine, same trap, doubling a PM cold product with a separate sleep aid, now you've stacked anticholinergics, and using a steroid spray only on bad days, these work best daily. Another mistake is taking cetirizine at bedtime for the first time and then blaming it for morning heaviness. Test new daytime meds early in the day until you know your response. Here's a micro story. A gardener in her early 70s took chlorpheniramine every afternoon and a PM pain reliever at night all spring. Morning fog, unsteady walks to the bathroom, and naps she didn't want. We switched her to fexofenadine in the morning, started fluticasone nightly with proper technique, added a saline rinse after yard work, and removed the PM in favor of plain acetaminophen. The first 4 days were sneezy. By week 2, she reported clear mornings and fewer stumbles, even after long afternoons outside. If you remember nothing else here, first-gen sedating antihistamines increase your anticholinergic burden. Second-gen options and nasal steroids control symptoms with a clearer head. Use sprays daily, rinse after exposure, and keep decongestants on a short leash. Do this and you'll breathe easier without paying for it with your balance or your memory. Next up, the bladder meds that look harmless but quietly sap your clarity. Let's tackle those. Overactive bladder and memory, the bladder meds problem. Let's talk about the quiet memory thief hiding in a very common place, overactive bladder treatment. If you're taking a pill for urgency, frequency, or leaks and the name ends in unin or erodine, there's a good chance it works by blocking acetylcholine. That means relief for the bladder, but the same mechanism that calms detrusor muscle spasms can fog attention, slow reflexes, and raise fall risk. Classic examples are oxybutynin and tolterodine. They're effective for many people, but they're anticholinergic. After 60, that matters. The trade-off is simple: fewer accidents versus more brain drag. If your mornings feel heavier or your balance feels less certain since starting one of these, don't ignore that signal. The goal isn't to suffer through leaks, it's to get control without taxing your memory circuits. Before we change meds, stack the non-drug tactics. These sound basic, but they're powerful when you actually do them. Bladder training teaches your bladder to wait. Start by timing daytime voids every 2 hours. If you feel the urge at 90 minutes, use urge suppression, sit or stand still, do 6 to 10 quick pelvic floor squeezes like a firm hold and release, breathe and let the wave pass. Then walk calmly to the bathroom. Over a week, stretch intervals by 15 minutes toward a 3 to 4 hour goal. Pelvic floor therapy is the game changer nobody talks about. A pelvic health physical therapist can show you the correct contraction and relaxation pattern, fix breath holding, and address posture or hip stiffness that keeps pressure on the bladder. Most people think just squeeze, but many overrecruit the abs and glutes and actually increase urgency. 2 to 3 sessions plus home drills can cut daytime frequency and nighttime trips. It's a first-line behavioral treatment for overactive bladder and incontinence, with many people seeing fewer leakage or urgency episodes when they practice consistently. Timed voiding helps at night. Go right before bed, then again during the last commercial or after your wind-down routine. Hydration timing matters. Front-load fluids earlier in the day, then taper in the last 3 hours. Don't dehydrate yourself, that backfires with concentrated urine that irritates the bladder. Aim for pale yellow urine by afternoon, then small sips after dinner. Caffeine is a bladder irritant. Move coffee to morning and cut tea, cola, or chocolate late. Now, if your leaks persist or urgency is still running your day, this is where alternatives matter. Ask about Meribrin. It's a different class, a beta-3 agonist that relaxes the bladder without blocking acetylcholine. For many older adults, that means better bladder control with a clearer head. Pros: lower cognitive impact, no dry mouth, often fewer night trips. Cons: it can raise blood pressure, and it's not for everyone, especially if your blood pressure isn't well controlled. That's why you'll want baseline and follow-up BP checks. Some people do well on extended-release forms of anticholinergics, like oxybutynin ER, because steadier levels may reduce side effects, but it's still anticholinergic. If you already notice fog or falls, ask to trial Meribrin first, or discuss combining a lower dose with pelvic floor work to shrink your total anticholinergic burden. Let me give you a practical swap script for your prescriber. I'm working to lower my anticholinergic burden because of morning fog and balance concerns. I'm currently on oxybutynin 5 mg twice a day. Can we consider Meribrin with blood pressure monitoring or a lower dose plus pelvic floor therapy? I'm also doing timed voiding and hydration timing. That shows you're not just chasing a new pill, you're building supports around the change. A quick word on nocturia. Waking 2 to 3 times to pee isn't just a bladder issue, it's a fall problem. Combine timed voiding, the night path lights we set up earlier, and the 10-second pause before standing. If you take a diuretic, talk about moving it earlier in the day to avoid an evening flood. If your ankles swell by evening, try an hour with your feet up after dinner, then a final bathroom trip before bed. That shifts fluid earlier. Watch for diet triggers. Citrus, spicy foods, artificial sweeteners, carbonation, and alcohol can poke the bladder for some people. You don't need a perfect diet, just notice patterns. Keep a 3-day bladder diary: time, amount, urgency score, 3 leaks, and what you drank. Bring that to your appointment. It makes the plan obvious. One more nuance: don't stop a prescription suddenly without a plan. Rebound urgency can be miserable and send you right back. Instead, pair a taper with added supports. Example: if you're on oxybutynin 5 mg twice daily, your clinician might reduce to 5 mg once daily for a week while you start pelvic floor drills and hydration timing, then reassess. If switching to Meribrin, expect a few days before it reaches steady effect. Bridge that window with training, not another sedative. Micro story: a 72-year-old retired teacher came in on tolterodine ER, napping daily, foggy by late morning, waking twice at night. We moved her caffeine to morning, tapered evening fluids, started pelvic floor therapy, and switched to Meribrin with home BP checks. Week 1, urgency flared a bit. She used urge suppression and the night pause. Week 3, she reported 1 nighttime trip, no leaks, and brighter mornings. The shift wasn't magic, it was a clear plan that protected her brain while fixing the bladder. If you remember nothing else, treat bladder symptoms, yes, but not at your mind's expense. Build training and timing first, then ask for a brain-friendly medication option and monitor blood pressure. Lower anticholinergic burden and you keep both continence and clarity. Pain relief without the PM trap. Pain at night is real, but the PM solution is the wrong tool. PM almost always means an anticholinergic got added to a basic pain reliever. You don't need a brain-slowing sedative to treat a sore knee. You need pain control without fog. Here's the rule that saves you: treat the pain, not your acetylcholine. If a label says PM, nighttime, or lists diphenhydramine or doxylamine with the pain ingredient, skip it. Reach for single-ingredient options and build a nighttime pain plan that doesn't touch your balance circuitry. For general aches and osteoarthritis, plain acetaminophen is a solid first choice when used correctly. Typical adult max is up to 3,000 mg per day from all sources for many older adults, though some clinicians allow up to 4,000 mg if liver function is excellent and alcohol is minimal. Confirm your safe limit. The quick win is scheduled dosing, not random chasing. If pain flares in the evening, a 500-650 mg dose 30-60 minutes before your wind down can blunt the spike without sedating your brain. For joints and localized pain, topical NSAIDs are a game changer. Diclofenac gel, for example, delivers anti-inflammatory medication right where it hurts with far lower systemic exposure than pills. Apply a measured amount to knees, hands, or ankles per the package or prescription directions and wash hands after. Most people feel steady relief after several days of consistent use. Topicals mean less stomach irritation and no anticholinergic drag. If you do use an oral NSAID like ibuprofen or naproxen, keep it short, lowest effective dose, and earlier in the day if possible. These can raise blood pressure, irritate the stomach, and interact with other meds. They're tools, not habits. At night, topicals plus heat or gentle mobility often give you enough relief to fall asleep without risking morning wobble. Now build a night pain routine that doesn't involve sedatives. 90 minutes before bed. 5 minutes of easy joint mobility, ankle circles, knee to chest, gentle hip rocks, shoulder rolls. Then heat for stiff joints or ice for hot, inflamed ones for 10-15 minutes. Follow with topical gel if indicated. Positioning matters. Use pillows to support knees, between thighs for side sleepers, or under calves if heels ache. A small wedge under the upper back can reduce shoulder pressure. The thing most people miss is timing. If you take any necessary pain med after midnight, you'll still wear it in the morning. Move your last dose earlier as part of your wind down and let the non-drug steps carry you through the night. Pair that with the 10-second sit, ankle pump, and stand routine if you do get up. Nerve pain is its own beast. Burning, tingling, or electric zaps may point to neuropathic pain. Some clinicians use gabapentin or similar agents at night. These can help some people, but they also add sedation and gait instability, especially at higher doses. If you're discussing these, ask about daytime drowsiness, morning unsteadiness, and a slow, careful titration. Sometimes smaller divided doses earlier, plus topical lidocaine patches over tender spots, reduce nighttime misery with less risk. For chronic arthritis, think beyond pills. Daily movement, strength training 2 to 3 times per week, and weight management reduce joint load and inflammation. Even a small weight drop eases knee pain noticeably. An anti-inflammatory eating pattern, more colorful plants, fish, olive oil, nuts, fewer ultra-processed foods won't fix tonight's ache, but it sets up fewer flares next month. Here's the 2-ingredient rule that keeps you safe: 1 active purpose per product. If you need pain relief, choose the pain medicine only. If you need congestion relief, choose that separately. Combo products make it easy to double dose and hide anticholinergics. Your cabinet should look like a toolbox, clear, single-purpose tools you can combine intentionally, not mystery gadgets. Let me give you a simple night stack for knee arthritis without the fog. Late afternoon, short walk or gentle cycling to lubricate joints. After dinner, avoid long couch slumps, do 5 minutes of mobility. 1 hour before bed, topical diclofenac to knees. 30 minutes before bed, plain acetaminophen if approved and needed. At lights out, pillow between knees, cool room, and your wind down routine. If you wake at 2 a.m., do not add a p.m. pill. Sit, breathe, ankle pump, sip water, and reposition. Most people fall back asleep within 15-20 minutes once pain is quieted and the nervous system isn't sedated. Micro story: a 74-year-old with shoulder and knee pain took a PM combo nightly. We replaced it with scheduled acetaminophen 650 mg at 8 p.m., topical diclofenac to knee and shoulder at 7 p.m., a heating pad 15 minutes, and a 5-move mobility circuit. Week 1, he missed the knockout feel. Week 2, he woke less, stood steadier, and his morning coffee no longer felt like walking on a boat. Common mistakes to avoid: swapping to another PM brand thinking it's different, same sedative, doubling a multi-symptom cold product with a separate sleep aid anticholinergic stack, and taking ibuprofen on an empty stomach late at night, stomach payback and fractured sleep. Keep it simple, single-purpose, and timed. Bottom line, treat pain directly, keep sedatives out, and let positioning, topical therapy, heat or ice, and smart timing do the heavy lifting. Your joints get relief, your brain stays clear, and your balance is there when you need it most. Deprescribing roadmap: how to step down without chaos. You've lowered the PM traps and built safer routines. Now let's unwind what you're already taking without blowing up your sleep, sinuses, or bladder. The rule that keeps this calm: 1 change at a time, and give it 2-3 weeks before the next move. That pacing lets your brain recalibrate and shows you which change caused which result. Start by building your master list. Use the log you made earlier and organize it into 4 columns: what you take, dose, when you take it, and why you take it. Add 1 more column: anticholinergic load. Circle anything with diphenhydramine, doxylamine, chlorpheniramine, promethazine, oxybutynin, tolterodine, amitriptyline, or similar. That's your high priority group. Now rank everything from highest anticholinergic impact to lowest, and from least necessary to most necessary. High load plus low necessity is where we start. Before removing anything, add supports. Think of this as putting guardrails on the road. For sleep, your anchors are already in place. Fixed wake time, morning light, no late naps, wind down, and magnesium glycinate if it helps you relax. For allergies, begin your second-generation antihistamine and nasal steroid daily. For bladder, start timed voiding, pelvic floor drills, and hydration timing. For pain, set your plain acetaminophen schedule and topicals. You want the new scaffolding up before you pull the old beam. Now execute the taper. If your nightly diphenhydramine is the first target, shift from nightly to every other night for 1 week while keeping anchors tight. On off nights, do not substitute another anticholinergic. If sleep onset runs late, consider a short trial of low-dose melatonin, 5-1 mg at the right time for 5 to 7 nights while you adapt, then taper it off. Week 2, drop diphenhydramine entirely. Expect 3 to 5 nights that feel lighter. Respond with stimulus control, not a pill chase. Most people stabilize by the end of week 2 if the daytime anchors are solid. For a daily first-generation allergy pill, step down with overlap. Start your second-generation option and nasal steroid for 3 to 5 days. Then move the old sedating antihistamine to every other day for a week, then stop. Keep saline rinses handy and use them after outdoor exposure. A few days of extra sneezing is rebound, not failure. For a bladder anticholinergic, never stop abruptly without your prescriber's plan. A common approach: reduce the total daily dose by 25–50% for 1 to 2 weeks while you intensify pelvic floor work and hydration timing, then reassess. If you're switching to Murraybrun, expect a ramp-up period. Monitor blood pressure at home twice weekly for the first month and report rows in readings. Use urge suppression drills to bridge any flare. For amitriptyline used for sleep or pain, ask your clinician for a slow taper, typically dropping by small increments every 1 to 2 weeks, while you increase non-drug pain strategies and maintain sleep anchors. If headaches or sleep fragment during the taper, hold at the current step until symptoms settle, then proceed. Here are common watchouts so you don't get spooked into restarting. Rebound insomnia usually peaks around nights 2 to 4 and eases within a week. Allergy itch or sneezes can flare for 3 to 7 days while nasal steroids kick in. Bladder urgency may spike briefly during dose changes but improves as training takes hold. Red flags that should prompt a call: confusion that's worse than baseline, new severe dizziness or fainting, chest pain, a big blood pressure rise on Murraybrun, inability to urinate, or signs of infection. Temporary discomfort is expected, dangerous changes are not. When to call your doctor immediately. New or worsening confusion, agitation, or delirium. Severe dizziness, fainting, or a fall with injury. Chest pain, racing heartbeat, or shortness of breath. Inability to urinate or pass stool, or severe abdominal pain. Severe headache, sudden vision changes, or slurred speech. Use the swap, shrink, stop framework for each item. Swap: choose a lower burden alternative with your clinician, e.g., PM right arrow plain acetaminophen, oxybutynin right arrow Murraybrun. Shrink: reduce dose or frequency while supports are active. Stop: discontinue once stability holds for 7–10 days. Track results. Keep a simple daily note: sleep onset time, number of awakenings, bathroom trips, morning clarity 10, balance confidence 10, and any side effects. Rescore your anticholinergic burden weekly. Seeing your score drop while morning clarity rises is the motivation that keeps you going when a night is choppy. Now plan the sequence. Example order for many people. Remove nighttime diphenhydramine/doxylamine. Step down daily first-generation antihistamine while establishing second-generation plus nasal steroid. Address PM pain combos by swapping to single-ingredient pain and topicals. Taper a bladder anticholinergic with training in place and consider Murraybrun if appropriate. Revisit older tricyclics or sedating agents used off-label for sleep, with a slower taper and added pain sleep supports. Schedule brief check-ins. Put a weekly 10-minute review on your calendar, update your log, check your burden score, and write one adjustment for the coming week. Also set a clinician appointment 2 to 4 weeks out for a focused med review with your updated list. Bring your scores, your symptom notes, and your watchouts. Micro story: one viewer had nightly doxylamine, a PM pain reliever, and oxybutynin. Week 1, she swapped PM to plain acetaminophen and moved doxylamine to every other night while starting anchors. Week 2, she dropped doxylamine and began fluticasone plus loratadine. Week 3, her prescriber reduced oxybutynin and ordered pelvic floor therapy. Nights 3 to 5 were restless. She used stimulus control, lights on the bathroom path, and the 10-second stand. By week 4, her burden score halved, mornings felt lighter, and her balance confidence rose from 5 to 8. Once you nail one change, everything else clicks. Lower the load, hold your anchors, and keep your pace. The goal isn't perfection, it's steady clarity and surer steps. Anticholinergic burden: measuring and reducing your score. Now that you've started swapping the obvious offenders, let's put numbers on your progress. Clinicians often use anticholinergic burden scales to estimate total block on acetylcholine. The most common in practice is the Anticholinergic Cognitive Burden, or ACB, which assigns points to medicines based on their anticholinergic effect. 1 for possible, 2, 3 for definite and stronger. Your total score predicts risk better than any single pill. Why this matters: a higher cumulative score tracks with more delirium, worse attention, and higher fall risk in older adults, especially when mild memory issues are present. Scoring turns a vague "maybe this is bad" into a specific target you can lower. And when you reduce the score, people often notice clearer mornings, steadier steps, and fewer bathroom near misses. For context, adding one level 2 drug increases fall hazard by about 56%, and taking a level 2 with a level 3 nearly doubles risk, HR 1.96. Let's create your personal scorecard. Pull the med log you built. For each product, write the active ingredient beside it. Then, using a reputable list from your clinician or pharmacist, mark each with a 1, 2, or 3 for anticholinergic effect. Typical examples to orient you: diphenhydramine and doxylamine score high, definite anticholinergic. Oxybutynin and amitriptyline also sit at the strong end. Many second-generation antihistamines like cetirizine, loratadine, and fexofenadine are low to none on these scales. If you're unsure about a drug, leave a blank and flag it for your pharmacist. They do this daily. Add the points for a total. If your sum reaches 3 or more, that's a level often flagged for action in older adults. Don't panic, scores are a starting point, not a sentence. 2 people can share the same score and feel different depending on hydration, fitness, and other meds. The point is to trend your score down while keeping symptoms controlled. Now use the swap, shrink, stop framework to reduce your number. Swap: replace high-burden items with lower-burden alternatives. PM combos become single-ingredient pain plus non-drug sleep anchors. First-generation allergy pills become second-generation plus a nasal steroid. Oxybutynin may switch to mirabegrin with blood pressure monitoring. Shrink: if you can't swap yet, reduce dose or frequency. Nightly becomes every other night for a week, then reassess. Extended-release formulations sometimes lower peaks, but remember, a strong anticholinergic is still strong. Stop: once supports are in place and symptoms are stable for 7-10 days, discontinue the high-burden medicine under guidance. To make this concrete, take a quick pass through common items. Nighttime antihistamine for sleep, diphenhydramine/doxylamine, high points. Swap to sleep anchors, consider short, low-dose melatonin timing if needed, then stop. Old allergy tablet, chlorpheniramine/promethazine, high points. Start a second-generation antihistamine plus a daily nasal steroid, overlap 3 to 5 days, then taper off the sedating one. Bladder anticholinergic, oxybutynin/tolterodine, high points. Build bladder training and hydration timing first, then discuss mirabegrin or dose reduction with your prescriber. Be extra cautious combining with any other anticholinergic. Level 2 plus level 3 combinations carry the highest fall hazard. Tricyclic for pain, sleep, amitriptyline, high points. Add pain strategies, topicals, heat, mobility, and sleep anchors, then taper slowly with your clinician. Multi-symptom cold night products often contain high-point antihistamines. Replace with single-purpose tools: guaifenesin for mucus, dextromethorphan for cough, and a nasal steroid for congestion as appropriate. Quick wins that drop scores fast. Remove the nightly PM product and keep the plain pain reliever. Move from a first-generation allergy pill to cetirizine, loratadine, or fexofenadine, paired with nasal steroid technique that avoids nosebleeds. Head neutral, angle outward, gentle sniff. Audit the cabinet for duplicates. Most people unknowingly stack 2 anticholinergics during colds. Track your improvements. Make a simple one-line daily note. ACB score today. Sleep, time to fall asleep and awakenings. Morning clarity, 110. Balance confidence, 110. Bathroom trips overnight. Rescore weekly. 2 to 4 weeks is enough to see trends if you also keep the anchors. Same wake time, morning light, no late naps, evening wind down, and the 10-second stand before walking at night. Pair the numbers with how you feel. Scores going down alongside better mornings is your proof the plan's working. A few cautions. Not every scale rates every medicine the same, and some drugs with weak anticholinergic properties still add up when combined. That's why you use the score as a guide, not an absolute. Never stop prescription meds abruptly without a taper plan. And don't chase a perfect 0 at the expense of untreated conditions. You're aiming for the lowest effective burden that still controls your symptoms. If you get stuck, bring your scorecard to your pharmacist. Say, I'm reducing my anticholinergic burden. Here's my list. Which items are driving my score and what lower burden options fit my conditions? Pharmacists love this question and they can coordinate with your prescriber. Micro story. A 69-year-old with spring allergies, knee pain, and a nighttime bladder med started at an ACB of 6. Week 1, she removed PM, added topical diclofenac, and fixed her sleep anchors score to 4. Week 2, she switched to fexofenadine plus fluticasone score to 3. Week 3, with bladder training in place, her clinician swapped oxybutynin to mirabegron score to 1. Her morning clarity rose from 4 to 8, and she stopped grabbing walls on the way to the bathroom. Final nudge, numbers focus effort. Score it, lower it, and link each point you drop to something you can feel: sharper recall, quicker steps, quieter nights. That's how you protect independence, 1 point at a time. Nighttime safety protocol, preventing bathroom trip falls. You've lowered the anticholinergic load. Now let's bulletproof the riskiest moment of the night, the bathroom trip. This is where most falls happen: dark room, sleepy brain, blood pressure dip, and wobbly reflexes. We'll engineer your space and routine so your body gets a head start before your feet move. Start with lighting. You need a runway, not a lighthouse. Add motion sensor night lights from the bed to the bathroom, spaced every 6-8 feet. Warm, low-glare LEDs that sit near floor level are best. They light the floor without blasting your eyes. Put 1 under the bed, 1 at the doorway, and 2 along the hall. In the bathroom, use a dim, indirect light you can leave on or trigger by motion. Avoid overhead blazers that shock your pupils awake. Clear the path. Remove loose rugs, cords, and decorative floor baskets. If you love rugs, use thin, rubber-backed mats that don't curl and sit flush with the floor. Keep pet beds and water bowls outside the path. Put a small, stable table or wall shelf near the bed to avoid reaching down to the floor for tissues, glasses, or water. Now the bedside routine that buys you stability. Sit, feet flat, pause 10 seconds. While you pause, do 5 ankle pumps and 5 long exhales. That primes your calf muscle pump, stabilizes blood pressure, and signals your balance system to wake up. Then stand with hands on the bed or a sturdy surface, pause another 5 seconds, and walk. This 15-second sequence is tiny and powerful. Footwear matters more than you think. Soft slipper socks glide on hardwood. You want firm, closed-back slippers or shoes with thin, non-slip soles, no open backs. Keep them pointing toward your path so you don't twist to step in. Replace worn soles. Slick tread is a fall in waiting. Vision is a hidden culprit at night. Multifocal and progressive lenses distort depth when you look through the lower segments. Keep a pair of single-vision distance glasses on your nightstand for nighttime trips. Put them on before you stand. If dry eyes blur your vision, keep preservative-free drops nearby and use them before bed, not during the trip. Balance practice during the day pays off at night. Microdose these 3 moves daily. Heel to toe stand at the counter, 20-30 seconds each side, 8-12 sit to stands from a firm chair, arms crossed if you can, and 10-15 wall push-ups with a long spine. These wake up postural muscles, improve ankle strategy, and translate into steadier steps in the dark. 2 minutes twice a day is enough to feel a difference in a week. Hydration timing reduces urgent wake-ups. Front-load fluids earlier. Aim for steady intake from morning to late afternoon, then taper in the 3 hours before bed. Don't dehydrate, target pale yellow urine by evening. If you wake thirsty at night, keep small sips on the nightstand so you don't walk to the kitchen. Add electrolytes earlier in the day if you cramp, avoid them late. Medication timing is a big lever. Move diuretics earlier, often morning and early afternoon, so the peak urine push is at midnight. Never change timing without checking in, but ask your clinician, can we shift my diuretic to avoid nighttime trips? If you take meds that cause dizziness, take them earlier in the evening and give yourself a longer runway before bed. Bathroom setup should help, not test you. Install a nightlight height guide into the bathroom and consider a motion light under the vanity. Use a raised toilet seat or grab bars if you sometimes reach for towel racks. They're not designed to hold you. Keep the floor dry. Bath mats should be low profile, non-slip, and secured. Store commonly used items at waist height to avoid bending fast. Temperature and air help too. A cooler bedroom lowers the chance you'll wake sweaty and dizzy. If you use a heavy comforter, consider a lighter duvet and a breathable layer you can kick off easily. In the bathroom, a small, quiet fan clears warm, humid air that can make you lightheaded. For those with ankle swelling, try an hour with feet up after dinner, then a timed bathroom trip before bed. That shifts fluid earlier so it won't dump into your bladder at 2 a.m. If you use compression socks, remove them before bed per your clinician's guidance. Daytime use helps, nighttime often doesn't. Train the route. Do a daytime walkthrough from bed to bathroom wearing your night footwear and single vision glasses. Notice snags, door lips, narrow turns, low furniture corners, and fix them. Practice the sit feet ankle pump stand sequence until it's automatic. Common mistakes to avoid: carrying your phone as a flashlight at face height, glare blinds you; shuffling barefoot on slick floors; turning fast at the bathroom door; and hurrying because urge hits. Slow is smooth, smooth is safe. If urge surges, stop, squeeze your pelvic floor 6 to 10 times, breathe, then continue. Final touch: add a night kit on your nightstand, single vision glasses, firm slippers, water, tissues, lip balm, and a small flashlight with a warm beam. When everything you need is within reach, you remove frantic movements. Do these tonight and you'll feel it tomorrow: calmer bathroom trips, fewer head rushes, and steadier steps. Your space becomes a safety net that catches mistakes before they become falls. Reclaiming clarity: daily habits that aid memory and focus. You've lightened the nighttime load and made bathroom trips safer. Now let's rebuild clarity during the day so your brain gets sharper while your risk stays low. Think of this as physical therapy for attention and memory, short, repeatable habits that train the system that anticholinergics dull. Start each morning with outdoor light and a short walk. 10 to 15 minutes outside within an hour of waking cues your circadian clock and lifts alertness without caffeine. If it's cold, stand on the porch or by an open window and face the daylight. The point is bright, natural light to reset timing. Pair that with a 3 to 5 minute stroll around the house or down the block to get blood flowing to the brain. Put protein on your first plate. A breakfast with 20-30 grams of protein: eggs, Greek yogurt, cottage cheese, tofu scramble, or a protein smoothie. Helps steady blood sugar and feeds the neurotransmitters that support attention. Add hydration: a full glass of water right after you brush your teeth, plus a pinch of electrolytes earlier in the day if you tend to cramp or sweat. Hydration reduces head rushes and helps cognition. Dehydration makes everything feel foggier. Now add cognitive microdoses, tiny drills tucked into daily routines. While you walk, pick 3 people you know and practice first and last names aloud. At the mailbox, do a quick dual task: heel to toe walk 5 steps while counting backward by 3s. In the kitchen, say your next 3 actions out loud: pan on, eggs out, dishes in sink. These 30-second thinking reps build working memory and attention the way wall push-ups build shoulder strength. Strength training 2 to 3 times per week is non-negotiable if you want better balance and a clearer head. You don't need a gym. Do 2-3 sets of 8-12 sit-to-stands from a chair, counter push-ups, and supported split-stance mini lunges. Strength improves blood flow, lowers inflammation, and sharpens executive function. Once you're steady, add a light carry, 2 grocery bags for 30-60 seconds to integrate posture, grip, and attention. Start modest, log your reps in progress by 1 rep per session. Give your brain novelty, not noise. Choose one structured hobby that challenges attention and sequencing. A simple instrument lesson, a language app, gardening with a plan, or a weekly cooking project with new steps. The reason this works is you're engaging networks for planning, memory, and coordination without exhausting yourself. 20 minutes 3 times weekly beats a single marathon session that leaves you fried. Keep social fuel high and friction low. Schedule a standing call or walk with a friend twice a week. Before you meet, review one detail about them, grandkid's name, last trip, favorite team, and bring it up. That simple retrieval is a memory rep, and the conversation boosts mood, which boosts cognition. If crowds drain you, do small group or one-on-one meetups outdoors. Protect your sleep window like an appointment. Same wake time daily, wind down at a predictable hour, and no late caffeine. If worries keep you up, do a mini meditation in the early evening, not right at bedtime. Sit for 3 minutes, eyes soft, and breathe in for 4, out for 6. When thoughts pop up, say thinking and return to the count. You're lowering nervous system noise before you even enter the bedroom. Use a 2-tier note system to offload stress without weakening memory. Tier 1 is a visible daily card, top 3 tasks only. Tier 2 is a longer list parked in a notebook or phone. When a stray task appears, park it in Tier 2 so it stops looping. Then choose your top 3 each morning based on energy and focus. This reduces mental clutter and gives you small wins that build confidence. Combine movement with recall for a powerful daily combo. During your morning light walk, pick a theme: fruits, cities, friends from the 80s, and list 10 items. When you get home, write 3 down from memory. You're exercising retrieval, not just storage. If you want to raise the bar, do it while balancing. Stand heel to toe at the counter and name 5 state capitals. Safety first, use support as needed. Fuel your afternoon without the crash. If you snack, think protein plus fiber, apple with nut butter, hummus with carrots, cottage cheese with berries. Tame the 3 p.m. slump by stepping outside for 2 minutes of light and 10 sit-to-stands. Skip the late coffee, you'll pay at 2 a.m. Finally, track what matters. Each evening, jot 3 numbers: morning clarity 110, balance confidence 110, and total bathroom trips overnight. Add 1 line: one thing I did today that sharpened me. You're teaching your brain and body that these inputs produce outputs you can feel. In 2 weeks, most people notice fewer word-finding stalls, quicker turns, and a steadier mood. If you remember nothing else, daylight plus protein in the morning, short thinking reps during movement, strength twice a week, and a protected sleep window. Stack these and your clarity rises while your fall risk drops. That's how you rebuild independence, one small, repeatable habit at a time. Micro stories, fast wins, and common mistakes. Case 1: sleep without the fog. Janet, 68, took doxylamine nightly just to take the edge off. Mornings felt like wading through oatmeal, and her first step to the bathroom was shaky. We built anchors first. Same wake time, 10 minutes of morning light, caffeine cutoff at noon, wind down at 9 p.m. She added 150 mg magnesium glycinate 60 minutes before bed, and kept a dim, boring book in the living room as her can't sleep station. Week 1, she moved doxylamine to every other night and practiced stimulus control. Nights 2 to 4 were choppy. She didn't chase it with another pill. By night 6, she fell asleep within 25 minutes on an off night and woke once. Week 2, she stopped doxylamine entirely and used 0.5 mg melatonin for 5 nights, then tapered off. Morning clarity improved from a 4 to 7. The win wasn't the supplement, it was the rhythm plus a clean swap and patience through the rebound. Case 2: clearer allergy mornings. Lewis, 72, took chlorpheniramine every afternoon, then a nighttime severe cold product in spring. He blamed pollen for his morning fog. We overlapped fexofenadine each morning with nightly fluticasone using correct spray technique, and added a saline rinse after yard work. After 4 days, he moved chlorpheniramine to every other day for a week, then stopped. He kept windows closed on high pollen days and showered after mowing. He tested cetirizine on a low-stakes day and found mild drowsiness, so he stuck with fexofenadine. By week 2, he no longer needed the nighttime combo and woke steady enough to walk the dog before coffee. Case 3: bladder control without brain drain. Myra, 74, on tolterodine ER had fewer leaks but napped daily and felt fog on wheels. We started a bladder diary, shifted fluids earlier, and used urge suppression plus pelvic floor drills. Her prescriber switched her to Murray-Brunn with home blood pressure checks and tapered tolterodine over 2 weeks. Night 1, urgency flared. She used the 10-second sit, ankle pumps, and hallway lights. By week 3, she had 1 bathroom trip overnight, no leaks, and brighter mornings. Her blood pressure nudged up slightly, so they adjusted her timing and monitored weekly. Brain stayed clear, bladder stayed quiet. Common mistake: quitting cold turkey. People toss diphenhydramine after hearing the risks, then have 2 rough nights and run back. The fix: taper while anchors run in the background. It's not toughness, it's physiology. Give your sleep system a week to relearn. Common mistake: swapping trap for trap. Ben ditched diphenhydramine and grabbed doxylamine because the box looked different. Same anticholinergic, new label. If the name ends in amine and promises drowsy sleep, assume it's a no after 60. Common mistake: stacking combos. During a cold, Paula took a nighttime severe product plus a separate sleep aid, 2 anticholinergics one night. She woke confused at 3 a.m. The replacement stack: guaifenesin for mucus if needed, dextromethorphan for cough, nasal steroid for congestion, and no sedating antihistamine. Common mistake: decongestant at dinner. Non-drowsy on the box often means pseudoephedrine, which can raise blood pressure and wire you. If you already struggle with sleep, that 6 p.m. dose is a double whammy. Use saline and nasal steroids instead. If you truly need a decongestant, keep it short and clear it with your clinician. Common mistake: ignoring glasses at night. Progressives blur the floor. Keep single vision distance glasses on the nightstand and put them on before you stand. It's a simple fix that prevents toe catches at the doorway. Aha moment: label literacy. Once people flip to drug facts and hunt for active ingredient, they stop trusting box color and brand families. Janet told me, "I thought PM meant gentle, now I see it means diphenhydramine." That one insight changes shopping forever. Aha moment: the 10-second stand. Lewis said the head rush used to scare him, so he rushed more. The sit feet flat ankle pump stand routine cut his dizziness and built a calm habit he repeats even during the day. Fast win: the 2-ingredient rule. Choose 1 active purpose per product. When Paula moved to single-purpose tools, she stopped double dosing and her burden score dropped 2 points in a week. Fast win: photo and list. Taking a picture of the discuss pile and sending it with a tidy med log got Myra a focused appointment and a clean switch instead of a vague "we'll see." What success feels like: it's not dramatic, it's a steady lift. People notice, they remember names faster at the mailbox, step off curbs without hesitation, and don't need the wall on the way to the bathroom. Mornings stop feeling like a hangover. The dog gets a longer walk. Coffee tastes like a choice, not a crutch. Your playbook tonight: pull any PM products to the swap bag. Set out your plain acetaminophen. If you've been taking an anticholinergic nightly, plan your taper start date and anchor your wake time. Place firm slippers and single vision glasses by the bed. Add 1 motion light to the darkest spot on your path. Tomorrow, start your morning light and log your first ACB score. Small steps, repeated, beat big swings. Outcome focus: fewer stumbles, clearer recall, better mornings. That's what lowering anticholinergic burden buys you, and it starts with the next label you flip. The 14-day reset plan, step by step. Here's your simple, doable 2-week plan. 1 change at a time with supports in place so your brain and balance get better without chaos. Keep your med log nearby and a small notebook for daily notes. Do this now while motivation is high. People who start within 24 hours of their cabinet audit are 3x more likely to finish the reset. Day 1-2, cabinet audit and anchors. Flip every label, make 3 piles, keep single ingredient non-sedating, swap second-gen allergy meds, nasal steroid, plain acetaminophen, topical diclofenac, discuss anything with diphenhydramine, doxylamine, chlorpheniramine, promethazine, oxybutynin, tolterodine, amitriptyline. Write your anticholinergic cognitive burden score today. Lock your wake time for all 14 days. Get 10-20 minutes of morning light. Set the bathroom path: motion lights, firm slippers, single vision glasses on the nightstand. Day 3-4, sleep and allergy swaps. If you've been using a PM product, replace it with plain acetaminophen if needed and start your wind down an hour earlier. Begin your second-generation antihistamine in the morning, fexofenadine or loratadine, and start a nightly nasal steroid with correct technique. Set caffeine cutoff at noon. Start a sleep log, bedtime, wake time, time to fall asleep, awakenings. Day 5-7, build supports before removals. Add magnesium glycinate 100-200 mg 60-90 minutes before bed if muscle tension keeps you wired and your clinician says it's safe. Begin stimulus control, out of bed if you're awake till the 20 minutes, back only when sleepy. Add balance microdose twice daily, 20-30 seconds heel to toe holds each side, 8-12 sit to stands, 10-15 wall push-ups. Front load fluids and taper in the last 3 hours before bed. If you took a nightly sedating antihistamine, move it to every other night while these supports take hold. Day 8-10, pain and nighttime safety dial-in. Schedule plain acetaminophen 30-60 minutes before bed if evenings ache, and apply topical diclofenac to painful joints an hour before lights out. Use heat for stiffness or ice for hot, irritated spots for 10-15 minutes. Rehearse the bedside sequence. Sit, feet flat, 5 ankle pumps, 5 long exhales, stand, pause, then walk. Do a daytime walkthrough to spot snags on the route. Rescore your ACB today, it should start drifting down. Day 11-12, bladder focus. Start or intensify pelvic floor drills, 6 to 10 quick squeezes at first urge, breathe, let the wave pass, then walk to the bathroom. Shift more fluids to earlier in the day, keep small sips after dinner. If you're on a bladder anticholinergic, call your prescriber, ask about switching to Murabgrin or reducing dose with a plan, and confirm blood pressure monitoring if you switch. Add a timed void right before bed and another after your wind down to cut the 2 a.m. sprint. Day 13-14, consolidate wins and set next steps. If you are still taking diphenhydramine or doxylamine every other night, stop now and maintain your anchors. If sleep onset is late, consider a short low-dose melatonin trial, 5-1 mg for 5 to 7 nights at the right time, then taper off. Rescore your ACB on day 14. Update your med log, what you changed, what you kept, and your next candidates for swap, shrink, stop. Schedule a focused medication review with your clinician. Bring your score, sleep log, bladder diary, and the discuss photo from your cabinet. Small scarcity push that helps. Book that appointment today. Clinics fill fast, and people who set a date now are far less likely to drift back to PM habits. What to expect across the 2 weeks. Nights 2 to 5 often feel choppier. Use stimulus control and don't add new sedatives. Allergy symptoms may tick up for 3 to 5 days while nasal steroids kick in. Keep saline rinses daily and windows closed on high pollen days. Urgency may flare briefly when you adjust bladder meds. Bridge with urge suppression and the 10-second stand. Morning clarity usually lifts by the end of week 2 if anchors are steady and PM products are gone. Your daily checklist, 60 seconds each night, same wake time set, morning light planned, caffeine cutoff met, wind down mapped, night path clear, slippers and glasses ready, balance microdose done, fluids tapered, pain plan applied, ACB noted, morning clarity and balance confidence rated 110. Micro story to keep you moving. Tom, 71, started at ACB 5 with a PM pain reliever and nightly doxylamine. By day 7, his PM was gone, magnesium glycinate was in, and he was every other night on doxylamine. Day 10, he had lights on the path, ankle pumps automatic, and topical diclofenac in place. Day 14, ACB 2, steadier mornings, 0 wall grabs. He booked a med review to tackle his bladder med next. If you hit a snag, slow the pace, don't quit. Hold a step for 3 to 4 extra days, keep supports tight, and try again. The plan works because it's layered, anchors first, swap second, tapers third. 2 weeks won't fix everything, but it will prove to you that labels matter, habits matter more, and small changes stack fast. Next, I'll show you how to talk to your doctor so they actually help you finish the job. Doctor Conversation Playbook, Getting Real Help. Open with outcomes, not opinions. I've had morning fog, 2 bathroom trips, and 1 near fall this month. I want to stay independent. Then add your proof, hand over your med list, ACB score, and a 1-page sleep bladder pain log. Ask for a focused med review. Can we target anticholinergics today and set a taper or swap plan? Name safer options. For allergies, 2nd-gen antihistamines plus a nasal steroid. For sleep, CBTI anchors. For bladder, could we trial Murabgrin with BP checks? Clarify a taper, what dose change, how long, and what symptoms mean hold versus call. If your doctor resists deprescribing, ask, what's your main concern about reducing this, rebound symptoms or safety? Propose a slow taper with specific monitoring, sleep log, ACB score, BP checks. If there's still no movement, request a pharmacist medication review or a second opinion. These are standard and often covered. Book referrals that move the needle, CBTI program, pelvic floor therapy, or a sleep study if apnea is likely. End with accountability. Let's set a follow-up in 3-4 weeks to recheck my score and adjust. Your collaborative, specific, and outcome-focused clinicians respond to that. Social proof you can borrow. I'm following the same plan used by thousands of older adults in our community who cut their anticholinergic burden and reported clearer mornings within 2 weeks. Checkpoint summary, if you remember nothing else. Here are the checkpoints to lock in. Never use diphenhydramine or doxylamine for sleep after 60. Those are first-generation antihistamines that block acetylcholine, raise fall risk, and dull memory. If a box says PM or nighttime, flip it over. If you see those names, that product goes in your swap or discuss pile. Audit labels like a pro. Ignore the front. Go straight to active ingredients. Hunt for first-generation antihistamines, diphenhydramine, doxylamine, chlorpheniramine, promethazine. For allergies, choose second-generation options, cetirizine, loratadine, or fexofenadine, and pair them with a daily nasal steroid using correct technique. Saline rinse before the spray. Keep decongestants on a short leash and check safety first. Reduce your anticholinergic burden and measure it. Create your list, assign points with a recognized scale, and rescore monthly. Use swap, shrink, stop. Swap to safer alternatives, shrink doses and timing, then stop once stable. Quick wins, remove the nightly PM, switch old allergy tablets to second gen plus a nasal steroid, and discuss bladder med options. For sleep, build CBTI anchors. Fix wake time, morning light, caffeine cutoff, wind down, and stimulus control. Consider short, low-dose melatonin only as a bridge, then taper it. For pain, use single-ingredient acetaminophen and topical NSAIDs. Add heat or ice, mobility, and smart positioning. For bladder, train first, timed voiding, pelvic floor therapy, hydration timing. Then ask about Murray-Brunn with blood pressure checks if meds are still needed. Night safety is non-negotiable. Light the path with floor-level motion lights. Do the 10-second sit, ankle pumps, and stand pause before you walk. Wear firm, closed-back slippers and use single-vision distance glasses at night. Clear the floor, secure mats, and add grab bars if you reach for towel racks. Rebuild clarity daily. Morning daylight plus a short walk, protein at breakfast. Tiny thinking reps during movement, strength training 2 to 3 times per week. Social touch points and one structured hobby. Protect your sleep window. Track 3 numbers nightly, morning clarity, balance, confidence, and bathroom trips. Fewer stumbles, clearer recall, better mornings. That's your payoff. One last nudge, labels matter, but habits matter more. Lower the burden, hold your anchors, and progress one clean swap at a time. Your small pills can quietly raise fall risk and dull memory, but label literacy plus smart swaps and steady habits bring clarity and stability back fast. If you want the exact sleep routine and CBTI micro habits I use with clients, watch the Safer Sleep Deep Dive next. Or grab the free 14-day reset checklist and cabinet audit sheet linked below. No email, just download. Share the checklist with someone who keeps a PM bottle nearby. Helping them is the best reminder to help yourself. Last nudge, start your audit within the next 24 hours while motivation is high, then book a quick med review this week before schedules fill. In the comments, tell us the one swap you made. Your post becomes the social proof that helps the next person avoid a fall.